Erectile dysfunction. In the past, declining sexual function was an inevitable consequence of advancing age, or it was brought on by emotional problems. This misconception, combined with men's reluctance to discuss their sexual problems, and physicians had inexperience dealing with sexual issues. Erectile dysfunction's prevalence in men with diabetes ranges from 35 to 75% versus 26% in general population. The onset of it also occurs 10 to 15 years earlier in men with diabetes than in counterparts without diabetes. A sexually competent male must have a series of events occur in multiple mechanisms intact for normal erectile function. He must 1. Have desire for his sexual partner, libido. 2. Be able to divert blood from the iliac artery into the corpora cavernosae. To achieve penile tumescence and rigidity, erection, adequate for penetration. 3. Discharge sperm and prostatic/seminal fluid through his urethra, ejaculation, and 4. Experience a sense of pleasure, orgasm. A man is considered to have it if he cannot achieve or sustain an erection of sufficient rigidity for sexual intercourse. Most men, at one time or another during their life, experience periodic or isolated sexual failures. The term impotent is used for men who experience erectile failure during attempted intercourse more than 75% of the time. Among women, evidence regarding the association between diabetes and sexual dysfunction are less conclusive. Studies have reported a higher prevalence of female sexual dysfunction in diabetic women as compared with non-diabetic. Female sexual function appears to be more related to social and psychological components than to the physiological consequence of diabetes. Let us look into etiology of erectile dysfunction. The causes of it are numerous but generally fall into two categories, organic or psychogenic. The organic causes can be subdivided into 5 categories: vascular, traumatic or post-surgical, neurological, endocrine-induced, and drug-induced. Examples of the psychogenic causes are depression, performance anxiety, and relationship problems. In people with diabetes, the main risk factors are neuropathy, vascular insufficiency, poor glycemic control, hypertension, low testosterone levels, and possibly a history of smoking. Why do men with diabetes have erectile dysfunction? The causes of erectile dysfunction in men with diabetes are complex. It involves impairment in nerve, blood vessel, and muscle function. Erection. To get an erection, men need healthy blood vessels, nerves, male hormones, and a desire to be sexually stimulated. Diabetes can damage the blood vessels and nerves that control erection. Therefore, even if you have normal amounts of male hormones and you have the desire to have sex, you still may not be able to achieve a firm erection. Other causes of erectile dysfunction are obesity, high blood pressure, high cholesterol, hormonal problems such as low testosterone, psychological problems including stress, anxiety, and depression, nervous system problems including damage to spinal cord or brain, smoking, drinking too much alcohol, and using some illegal drugs. Some medications such as those taken for high blood pressure and depression. Pelvic injury or surgery on the prostate, bowel or bladder may cause damage to nerves connected to the penis. This nerve damage can also lead to ED. A doctor will often perform some of the following tests to diagnose ED. Blood tests to check for a raised blood sugar level, which may indicate diabetes. Hormone tests to measure the levels of testosterone and other hormones. Nervous system tests, such as blood pressure and sweat tests, which can rule out nerve damage to the heart, blood vessels, and sweat glands. Urinalysis to test for sugar in urine, which might indicate diabetes. Physical examination to assess the genitals and nerve reflexes in the legs and penis. Patient history to help determine why someone is having problems with erections and under what circumstances. Sexual health questionnaire to help diagnose the presence and severity of ED. Injection of a drug into the penis to check that the blood supply to the penis is normal. There are some lifestyle tips for preventing ED. Keeping diabetes under control is a good way to reduce the risk of erectile dysfunction. Erectile dysfunction due to diabetes is much better understood now. Good control of diabetes can reduce the risk of ED. Other preventive measures such as stopping smoking and reducing alcohol intake will lower the risk of developing ED. Other lifestyle changes that may help include eating a healthy diet and taking exercise. Studies suggest that men who changed their diet to one low in saturated fat and high in fiber and did moderate physical activity each week were able to improve ED without prescription drugs. Weight loss. Some studies show that even a small weight loss can improve erectile function and sexual desire in men with diabetes. Those who lost weight had increased testosterone levels and blood flow, resulting in better erections. Stress reduction. ED can cause stress and tension in a relationship. Counseling can be helpful even if the origins of sexual dysfunction are physical. People with ED should try to find time for relaxation and get enough sleep every night. A study suggests that supplementation with amino acids called l-arginine and l-citrulline may also help to improve erectile function. These acids are known to increase the body's production of nitric oxide, which can increase blood flow to the penis. As stated previously, low levels of nitric oxide are often found in men with diabetes. What is the treatment for erectile dysfunction? Initially, preventive measures will help reduce the risk of developing ED. Improving glycemic control and hypertension, ceasing cigarette smoking, and reducing excessive alcohol intake have been shown to benefit patients with ED. Avoiding or substituting medications that may contribute to ED is also helpful. Onset has developed, oral agents are considered first-line therapy. Sildenafil, Viagra, acts by blocking the catabolism of cGMP, resulting in an increase in nitric oxide. 56% of diabetic men with ED experience improvement with sildenafil, compared to 70% of non-diabetic men with ED. Sildenafil should be taken 1 to 2 hours before intercourse. It is important to tell patients that the drug's effectiveness requires sexual stimulation. The initial dose for sildenafil is 50 mg, and the dose can be increased to 100 mg. The pills can also be split in half. Side effects of sildenafil are similar to those from taking niacin or any vasodilator. They include headaches, lightheadedness, dizziness, and flushing. Some experience a bluish tinge of their cornea, which makes them feel as if they are wearing light blue tinted sunglasses. This effect can last for several hours. Syncope and myocardial infarction, the most serious side effects, are seen in men who are also taking nitrates. Sildenafil also has adverse effects in people with hypertrophic cardiomyopathy. It is because a decrease in preload and afterload in the cardiac output can increase the outflow obstruction, culminating in an unstable hemodynamic state. Other men for whom its use holds potential hazards include those with heart disease, active coronary ischemia, example positive exercise tolerance test, who are not taking nitrates, congestive heart failure, CHF, and borderline low blood pressure or low volume status, people under a complicated multi-drug antihypertensive regimen, people who use drugs that prolong the half-life of sildenafil by blocking CYP3A4. Another oral treatment that has been used with very little success is yohimbine, Yohimex. This is an alpha-2 adrenergic receptor blocker that increases cholinergic and decreases adrenergic tone. It stimulates the midbrain and increases libido. Optimal results occur when used in men with psychogenic ED. Side effects include anxiety and insomnia. Certain other parade-5 inhibitors used to treat ED are vardenafil, Levitra, tadalafil, Cialis, and Avanafil, Spedra. These drugs cause an erection by increasing blood flow to the penis. They require sexual stimulation to be effective. They should be taken 30 to 60 minutes before sexual intercourse. For those patients who are not candidates for oral therapy, intracavernosal injections are an acceptable alternative. Injections with alprostadil, Caverject, and papaverine, Genopid, have been used to induce erection. This form of therapy has a response rate of well over 70%. The sympathetic nervous system normally maintains the penis in a flaccid or non-erect state. All of the vasoactive drugs are injected into the corpora cavernosae. They inhibit or override sympathetic inhibition to encourage relaxation of the smooth muscle trabeculae. The rush of blood engorges the penile corpora cavernosae sinusoidal spaces and creates an erection. Patients who use this therapy should be trained under the guidance of a neurologist, and sterile technique must be used. The drugs must be injected into the shaft of the penis and into one of the penile erectile bodies. Corpus cavernosae, 10 to 15 minutes before intercourse. Most patients do not complain of pain upon injection. Sexual stimulation is not required, and resulting erections may last for hours. Side effects include penile pain and priapism. The cost is about $12 to $20 per injection. Intraurethral alprostadil, MUSE, provides a less invasive alternative to intrapenile injection. It is a pellet that is inserted 5 to 10 minutes before intercourse, and its effects last for 1 hour. The response rate is 50 to 60%. It can be used twice daily but is not recommended for use with pregnant partners. Complications of priapism and penile fibrosis are less common than after alprostadil given by penile injection. Intraurethral injection. The cost is $18 to $24 per treatment. Mechanical therapy is also effective and is especially well accepted in men with stable partners. Vacuum-assisted erection devices are effective in creating erections in as much as 67% of cases. Vacuum pressure encourages increased arterial inflow, and occlusive tension rings discourage venous outflow from the penile corpus cavernosae. The penis placed inside the cylinder, a pump is used to produce a vacuum that pulls the blood into the penis. The inflatable prosthesis has a pump that is put in the testicular sac for on-demand inflation and deflation. After the tension ring is slipped onto the base of the penis, the cylinder is removed. Erection lasts until the rings are removed. The one-time expense of this therapy is $120 to $300. Penile prosthesis is a viable option for men who cannot use sildenafil. It is also an alternative to who find the injections or vacuum erection therapy distasteful. A non-adjustable semi-rigid prosthesis is easy to insert and has no post-operative mechanical problems. Future versions will have a remote control device similar to a garage door opener. The primary complication of the surgical implantation is post-operative infection. It occurs in about 8% of cases involving diabetes. This infection can be difficult to treat. It may require the removal of the device, although this occurs less than 3% of the time. The infection can also cause penile erosion, reduced penile sensation, and autoinflation. Glycemic control should be optimized several weeks before surgery. Once a patient has surgery, none of the oral agents or vacuum devices will work because of the destroyed penile architecture. Testosterone therapy with injections or patches should be tried in patients with documented low testosterone levels. Testosterone deficiency is a rare cause of impotence but should always be ruled out with a serum value. Psychotherapy should be offered to the patients and their partners to address any interpersonal conflicts. Erectile dysfunction is a problem for couples, not just men. To conclude, ED is an under-recognized, under-discussed, and commonly untreated complication of diabetes. But it is also one of the most treatable diabetic complications. It is a couple's disorder, affecting both the patient and his partner. Knowledge of sexual dysfunction is rapidly expanding, and effective new treatments are now available. They include oral medications, injectable drugs, vacuum devices, and inflatable prostheses. It is therefore important for patients to be educated and aware of the causes and treatments of ED.